Hello, welcome my friends and colleagues in new video of our YouTube channel. Number 1 Doctor. Today we'll have a lecture. Hope you enjoy, get benefits. But before we start the lecture, do not forget to subscribe to our YouTube channel Number 1 Doctor. Like the video, share the video on social media. Follow us on our social accounts below the description. If you have any ideas, leave it in comments below the video.
Okay, doctor. Can we start the lecture now?
Okay, we will start soon.
Is shock, hemorrhage and blood transfusion. So first of all, let's start with shock. Before beginning shock, what we need to understand is the definition of hypotension. It is essentially defined by two criteria, either a systolic BP of less than 90 mmHg or a diastolic or a mean arterial pressure MAP of less than 65 mmHg. Okay, so hypotension is defined either as a SBP of less than 90 or an MAP of less than 65. So shock. The first thing that you need to know is that shock is the most common cause of death in surgical patients. So shock is the most common cause of death among surgical patients. Okay. Now let's begin with the first thing, the clinical features or signs in a patient of shock. The first thing that you can see in a patient of shock is tachycardia, along with vasoconstriction. Okay, and the vasoconstriction is preferentially peripheral vasoconstriction. And this peripheral vasoconstriction will lead to cold extremities. Okay. Now, why does tachycardia and vasoconstriction occur in a patient of shock? This occurs due to increased sympathetic overactivity. There is increased overactivity of the sympathetic nervous system, which leads to tachycardia and vasoconstriction, and this occurs so that more blood can be diverted towards vital organs. Okay, increased sympathetic overactivity. Then the next clinical finding which you can find in this patient is increased respiratory rate. Now, why does there is an increase in respiratory rate? This occurs so that minute ventilation can be increased. Increased minute ventilation. And why does there is an increase in minute ventilation? This occurs so that an increased amount of CO2 can be washed out from the body to remove excess CO2. And why does the body need to wash out more amount of CO2? To counteract, here comes the fifth clinical finding, metabolic acidosis. So, and why does metabolic acidosis occur? Due to lactic acidosis. So, due to shock, the tissue perfusion decreases. So there is increased lactic acidosis in the cells. There is increased lactate in the blood. Lactic acidosis occurs, which leads to metabolic acidosis, And to counteract that metabolic acidosis, the respiratory rate increases so that more amount of CO2 can be washed out from the body as a compensation, so that the pH of the patient can be kept at a normal range. Seventh point, there will be decreased urine output. Now this is a late finding. Okay, as I told you initially, there is peripheral vasoconstriction, so the blood flow is maintained to the vital organs, out of which kidney is one of the organs. So blood flow to the kidney is maintained in the initial stages of the shock, but in later stages, as the blood flow decreases, the renal perfusion decreases and there is decreased urine output. Decreased urine output due to decreased perfusion. Eighth, edema. Now edema is not a common finding in shock. It occurs mainly in distributive shocks such as anaphylactic shock or septic shock. These are the two main types of shock, anaphylactic and septic shock, in which edema occurs. And edema occurs due to endothelial leak. In both anaphylactic shock and septic shock, certain mediators are released in the blood which lead to increased permeability of the endothelium, and hence tissue edema occurs. Okay. The last thing, there is increased cortisol as well as increased vasopressin. And the increase in both occurs to conserve more amount of sodium and water in the body. Okay, so moving on. Next thing that we need to know is the classification of shock. So the first type of shock is hypovolemic shock. Hypovolemic shock, it can be due to dehydration, excess amount of diarrhea. Okay, so hypovolemic shock. Second is hemorrhagic shock. Now hemorrhagic shock in some of the classifications is also classified as a subtype of hypovolemic shock, because essentially in hemorrhagic shock there is decreased amount of blood, so hypovolemia can occur. In some of the books, in some of the classifications, hemorrhagic shock is a subtype of hypovolemic shock. Then the third type, cardiogenic shock. Cardiogenic shock is essentially a shock due to cardiac dysfunction. It can occur in patients of MI, angina. Okay, in these patients who have a cardiac cause, in those cases if shock occur, it's called a cardiogenic shock, most commonly seen in patients of MI. Okay. Fourth, obstructive shock. Now what is this entity? Obstructive shock essentially is a shock caused due to cardiac dysfunction due to external cause. There is no intrinsic cardiac defect, but there is an extrinsic compression or obstruction on the heart, due to which the dilation of the ventricles during diastole is decreased, and hence there is decreased amount of blood in the heart, there is decreased preload, which leads to decreased cardiac output, and hence the patient enters into shock. And this classically occurs in two conditions. The first one is cardiac tamponade. The second one is tension pneumothorax. In both these conditions, there is extrinsic compression of the heart leading to diastolic dysfunction and hence shock. Okay. So how do we define obstructive shock? It occurs as a result of decreased preload due to decreased cardiac dilation during diastole due to extrinsic, compression, or obstruction. This is obstructive shock. Now, the next kind of shock is distributive shock. What does distributive shock means? In distributive shock, there is no cardiac dysfunction, there is no hypovolemia, but rather the blood or the fluid content of the body is distributed in in a way that the effective volume of blood decreases. Either there is increased vasodilation and hence the effective blood volume decreases, or a lot of water moves out from the blood into the tissues leading to tissue edema, and hence there is decreased blood volume. This kind of shock is called distributive shock. In distributive shock, there are essentially three kinds of shocks which come. The first one is the anaphylactic shock. The second one is the septic shock. And the third one is the neurogenic shock. Okay. Distributive shock essentially occurs due to excessive peripheral vasodilation or movement of excessive amount of fluid out of vessel. Plus minus. There will be excessive vasodilation which will always be present, and it is present in anaphylactic as well as septic as well as neurogenic shocks. Okay. So this peripheral vasodilation will always be present. Apart from that, excessive amount of fluid moving out of the vessels may or may not be present. It will be present in anaphylactic shock, it will be present in septic shock. As I told you, both of them have excessive tissue edema, but it is usually not present in neurogenic shock. So the first thing, excessive peripheral vasodilation, is present in all three, and this may or may not be present. Okay. Now, one question which is asked: the cause of vasodilation in anaphylactic shock. So the excessive vasodilation of anaphylactic shock is caused due to a certain mediator, which is histamine. It has been asked several times. So the vasodilation in anaphylactic shock is actually due to excess amount of histamine in the circulation. Okay. And the last kind of shock which is defined is endocrine shock. Due to endocrine dysfunction, and it occurs in two conditions. Classically, the first one is hypothyroidism. The second is adrenal insufficiency. Another thing that you need to know about shock is that it can be classified into, the first one is the compensated shock. The second one is the decompensated shock. Now, what is compensated shock? In compensated shock, the shock is occurring in the body, but the body is trying to respond to it and hence is trying to counteract it and is able to do so. That's the term, able to do so. The body is able to maintain the BP despite fall in blood volume, despite decreased contractility of the heart, but still by involving a lot of mechanisms, the body is still maintaining the blood pressure. If shock in a patient of shock, the BP persists at a normal level, that is compensated shock. Okay, so in compensated shock, first thing you need to know, the response from the body is present. which is effective. An effective response is present from the body. So, and blood flow is maintained to the vital organs. So, to kidney, lungs, and brain. But to the other organs, which are muscles, GIT, and skin, the blood flow is reduced, but decreased to GIT, muscles, and skin. So, the clinical features which we will find in a patient of compensated shock are: first thing, as the circulation to the skin has reduced, you will find cold and clammy skin. Apart from them, since there is a compensation present, so tachycardia will be present. Okay, these are the most common clinical findings in a patient of patient of compensated shock. The patient will mostly present with cold extremities and a tachycardia, and the BP will be normal, respiratory rate will be normal, everything just tachycardia and cold and clammy skin. And this kind of shock, the compensated shock, usually is present up to 15% of blood volume loss. So present usually up to 15% blood loss. Okay. Now, what is decompensated shock? Decompensated shock, there is global hypoperfusion. Despite the mechanisms which the body has started, the BP can't be maintained. The BP has fallen, and the blood flow to the three vital organs which the body was trying to maintain: the heart, the lung, the kidneys, and the brain. All these three organs also now are not receiving the adequate amount of blood. So there is global hypoperfusion. And once this occurs, the other sign which I told you, decreased urine output, lactic acidosis, metabolic acidosis, these will set in. And hence, the patient will present with all these symptoms. So decompensated shock is defined as a case of global hypoperfusion. There is failure of counter mechanisms. Okay. And other signs also develop. The other sign which I told you of shock, they will also develop in this patient. So compensated versus decompensated. Up to 15% blood volume loss, body can easily compensate, and the body is in compensated state of shock. Okay. And at this time, the body, there is tachycardia, there is vasoconstriction, and the blood flow is maintained to the vital organs. But once there is excess amount of blood loss, the excess amount of blood volume has decreased more than a certain amount. Now the body can't compensate it for it, and the patient goes into decompensated shock. Okay. So management of shock. The first thing that you need to do in a patient of shock is to give the patient a large amount of fluids. So the first thing that we'll see is fluids. Told you, this is the first thing you give. So fluids is the first line management. Okay, the first line management of shock is fluids. Now there are crystalloids, there are colloids, and there is blood. Out of these, there is no ideal fluid. Except blood. But blood is an ideal fluid in hemorrhagic shock. Okay. If I ask, out of crystalloids, out of colloids, RL, RL, normal saline, D5, DNS, N/3 D5, albumin, starch, what is the ideal fluid? There is no ideal fluid. Okay. It depends on what the condition is. So the options of fluid that we have in these patients are: first, crystalloids; second colloids, third is blood. As I told you, blood is ideal for hemorrhagic shock. Okay, blood is an ideal fluid for hemorrhagic shock. Now, out of crystalloids and colloids, there's one thing you need to know, that these will only increase the blood volume. These will not improve the oxygen carrying capacity of the blood because they have zero O2 carrying capacity. Okay, and what will you prefer out of crystalloids and colloids? Crystalloids. So crystalloids are preferred over colloids. Okay, now you have given the patient with fluids, but the patient is still not responding. Now, what is the second line management? The second line management is vasopressors. And inotropes. There's a difference between the two, vasopressors and inotrope. Vasopressors are drugs which essentially cause vascular constriction, and that too venous preferentially. Okay, whereas inotropes, they are acting more on the heart and they increase the contractility more than vasoconstriction. Both will cause vasoconstriction, vasopressors with inotropes, but the predominant action defines whether the drug is a vasopressor or the drug is an inotrope. If it's preferentially acting on the vessels more than, if the action is more on vessels, it causing more contraction as compared to its effect on the heart, in that case it's a vasopressor. But if it's increasing contractility more as compared to vasoconstriction, then it's an inotrope. Okay, so vasopressors and inotropes are the second line drugs. Second line for hypovolemic shock. Okay, now one thing, the guidelines which are the management of shock which we are talking about is essentially hypovolemic shock. Okay, not the other kinds. So the first line was fluids, the second line was vasopressors. Now if we talk about adrenergic agonists, these are two. There are two adrenergic agonists that we essentially use in these patients. The first is noradrenaline, and second is phenylephrine. Okay, now there's one thing you need to know about noradrenaline and phenylephrine. These are more of vasopressors. Okay, so these are more effective in those kinds of shock in which there is peripheral vasodilation. So these are more effective in patients of distributive shock. Okay, now the second category is the inotropes, and in this, the one which we most commonly used is the dobutamine. And since it's an inotrope, it will increase cardiac contractility, so it's more effective in cardiogenic shock. More effective for cardiogenic shock. Okay, now once you have started giving the patient fluids, you have started giving the patient inotropes, vasopressors, how will you monitor the patient? So monitoring. Okay, Now the first thing that you need to know is the most accurate method. The second thing that you know is the best method. What is the most accurate method? The most accurate method to monitor a patient of shock is central venous pressure. Okay, and the best method to do that, to monitor a patient, is the urine output. As you know, the normal value of CVP is 0 to 8 mm. Sorry, 0 to 8. Okay, and urine output, as I've already told you before also, for adults, if your resuscitative measures are adequate, if you are providing the patient with adequate therapy, then in a patient of shock, in adult, the urine output should be more than 0.5 ml per kg per hour. If the patient is in pediatric population, in that case, it should be more than 1 ml per kg per hour. And if it's an infant, then it should be more than 2 ml per kg. So, adult more than 0.5, peds more than 1, and infant more than 2. If this is the urine output of the patient, then in that case, you are providing the patient with adequate resuscitative measure. So the next topic that we need to do is MVOS, or mixed venous oxygen saturation. This is a new entity recently been included in the course. Okay, has been included in the latest edition of the Baileys. Now, what is MVOS? MVOS essentially reflects the percentage of oxygen which is bound to the hemoglobin coming to the right side of the heart. We measure the oxygen saturation in percentage values of the blood in the right atria coming from the whole body, and then we measure it, and this percentage of oxygen, what it essentially shows it what is the leftover oxygen after the whole body has utilized the oxygen that it needs. The blood has gone through the whole body. So if from the left atria, the blood went to left ventricle, and from there by the aorta, the blood went to the whole body. So if by the aorta, if we assume that in aorta the oxygen bound was 100%. Okay, the saturation was 100%, and then we measure in the right atria. Once the blood comes from the SVC and the IVC, the blood comes into the right atria, and we measure the saturation, which is X. So this X is MVOS. And what does this X reflect is that what is the leftover amount of oxygen in the blood after the body has utilized the amount of oxygen that it needs. So if the body has taken 20% of oxygen out of the blood, GIT, everything combined has utilized 20% of oxygen. So then X in this case will be 80%. Okay, this is what MVOS is. So if we define it, we'll define it as percentage of oxygen bound to hemoglobin in the blood returning to the right side of heart. This is MVOS, and it is represented by the symbol SVO2. Okay, and what it reflects is, so it reflects the amount of oxygen which is left over, okay, left over after tissues remove what they. So the left amount of oxygen in the blood is the SVO2. Now what is the use of this? It helps us to classify shock, okay, but before that, what is the normal value? The normal value of SVO2 is 60 to 80%. It lies somewhere between this range. Okay, so this is normal value. Now how will you classify shock based on SVO2 or based on MVOS? So if the these are the two broad categories which is defined. Patients with MVOS or SVO2 less than 50% and the other category more than 70%. If a patient of shock has an SVO2 less than 50%, this essentially means that the tissues are utilizing a larger amount of oxygen from the blood. The uptake of oxygen from the blood by the tissues has increased. So it occurs in cardiogenic shock and hypovolemic shock. What is essentially happening in cardiogenic and hypovolemic shock is that in cardiogenic shock, if we say there is stasis of the blood, the heart is not able to pump the blood effectively, so the blood is staying in the circulation for a longer duration of time before getting oxygenated into the lungs. Okay, so there is a backlog of blood in the veins. So the cells are in since the cells are in more the cells are in contact with that blood for more time, the cells will take up a larger amount of oxygen from that blood. Okay, so since the cells are in contact with the blood for a longer time, a larger amount of oxygen will be taken up from the blood, and hence the saturation or the percentage of oxygen left in the blood which is coming to the heart will be lesser. Similarly, in hypovolemic shock, there is lesser amount of blood in the circulation. So the amount of blood reaching to the cells or to the organs is less. So hence, now to fulfill the requirement of the oxygen, the organ and the cells will take more amount of oxygen from this decreased amount of blood. And hence, the SVO2 also will decrease in this case. So less than 50 means that there is increased O2 consumption by cell. This will happen in a case of cardiogenic shock since there is increased stasis, and in hypovolemic shock since the amount of blood has decreased. So to maintain the equal amount of oxygen being delivered to the cell, more amount will be taken up from the blood. Okay. Now, what does more than 70 mean? The blood is reaching to the cells, but cells are not taking up adequate amount of oxygen. Either there is inflammation or there is cellular necrosis or anaerobic condition have been created in those organs, leading to decreased uptake of oxygen from the cell. So this happens mainly in septic shock and distributive shock. Distributive shock. But if asked, so septic shock more than distributive shock. That's why I have written it as separate entity. We know that septic shock is a part of distributive shock, but I have written it separately because if both are given in the option, then in that case you have to choose septic shock more than distributive shock. So septic shock, essentially what is happening is that there is acidosis, that there is an anaerobic environment, the cell, there are a lot of mediators which are cellular toxic. So hence the cell viability has decreased, the cell's functioning has decreased, and hence there is increased O2 left in the blood circulation. Okay. Another thing was asked in the recent examination, and that was modified shock index. What is the definition of modified shock index? Modified shock index is essentially a fraction obtained after dividing heart rate by mean arterial pressure. It is said to be a better indicator of shock as compared to either heart rate or mean arterial pressure taken alone. So it's a combination of the two. It's a fraction, and it's a better indication than either taking heart rate or MMP alone. Okay, was asked in the recent examination. Now in septic shock, in 2000, what I'm going to tell you now in septic shock is essentially taken up from the 2016 Society of Critical Care Medicine and European Society of Intensive and Critical Care Medicine (SCCM) and ESICM guidelines. These guidelines were updated in the Surviving Sepsis campaign, and in 2016, the SCCM and ESICM gave new guidelines of sepsis. So I'll be including those guidelines also in this video. Okay. So the first thing which came as a new concept in these guidelines was the SOFA score, also known as sequential organ failure assessment. Okay, this is a new score and a very important one. The importance of this score is that it helps us to predict severity of sepsis, and it is a predictor of morbidity due to sepsis more than mortality. It will tell us about the both, but if asked, mortality more a predictor of morbidity due to sepsis. Okay, now the SOFA score is essentially a score which includes values as a representative of all the organ systems. Okay, so there is one or two values which are used as a representative of a particular organ system, and the change in those values reflects that particular organ system is being affected by the process of sepsis. So it includes, for calculating this in this score, the criteria that are included are: first, for respiratory system, we use the ratio of PaO2 upon FiO2. For CVS, what we use is the amount of dopamine, epinephrine or norepinephrine which is required to prevent tissue hypoperfusion. Okay. Then the third, for hepatic system. For hepatic system, what we used is serum bilirubin as a marker of coagulation. What we use is the platelet count. As a marker of CNS, what we use is the GCS. And as a marker of renal function, what we use is the serum creat and urine output. Okay, these are the values, and using this we calculate the score. Now another score was recently introduced after these guidelines, known as the QSOFA or the quick SOFA, also known as the Sepsis 3 score. Now the use of this score is that it helps us to identify patients potentially at risk of sepsis. And And since it's supposed to be a quick score, it includes only 3 parameters. That's why it is also called a sepsis 3 score. And these parameters are a respiratory rate of more than or equal to 22 per minute, altered sensorium or mentation, and an SBP of less than or equal to 100 mmHg. Not 90 but 100 mmHg. Okay, this is the quick SOFA score. Now, a topic you are familiar with, you must have heard a lot about this, SIRS, or systemic inflammatory response syndrome. Now, what you don't know is that it is not useful according to new guidelines. It may still be used, but it is no more useful. And the reason what they have given for this is, first, that many of the patients in the hospital settings might meet the criteria of SIRS without having actual sepsis. Okay, so many patients in hospital may meet the criteria without any infection. Second, SIRS is not as good as SOFA in predicting mortality. So, not as good in predicting mortality as SOFA. But still it might be asked in the examination. So I'll tell you what SIRS is. A patient is said to be in SIRS if more than or equal to 2 of the following are present. First one is temperature more than 38 or less than 35. The patient should either be in hypothermia or hyperthermia. Second, heart rate more than 90. Third thing, respiratory rate more than 20 or a PaCO2 less than 32 mmHg. Okay, and the fourth thing is TLC more than 12,000 or less than 4,000. I'll give an example why these criteria are not good for predicting a patient response. But means why we can't use these criteria, these 4 criteria, as a predictor of developing sepsis or a predictor of developing mortality. Why SIRS is not a good concept nowadays is because, for example, it is a patient of normal surgery. If a patient has been operated, in the normal post-operative course of the patient, you will find all of these things. In a patient as a response to normal surgery, I'm not talking about sepsis, I'm not talking about anything. Elective surgery, a patient underwent an elective surgery. In the post-operative course, in the immediate post-operative course also, you will find all these things. As a response to the drugs, the patient might have hypo or hypothermia. The patients can develop fever due to a lot of the drugs that we give during the post-operative phase. Heart rate is present due to the stress of the surgery. There may be increased respiratory rate, and TLC count also increases in these patients. All the 4 criteria are met, but that doesn't mean that the patient is going to SIRS. But if we follow the older guidelines, it simply says if more than or equal to 2, we say that the patient is in SIRS. That's why it has now been replaced by SOFA score. Okay, we talked about SOFA, quick SOFA, SIRS. Now we were beating around all these bushes because we wanted to define sepsis. So how do you define sepsis in a patient? If we go with the old guidelines, what they say is that the patient should have systemic inflammatory response syndrome plus infection. If this patient of SIRS develops an infection, we say that the patient is in sepsis. Little bit vague. What does the new guidelines say? New guidelines say that the patient should have organ dysfunction, which is represented by an increase of more than 2 points, more than or equal to 2 points, increase of 2 or more points on the SOFA score. Okay, so when do we say that the patient is developing organ dysfunction? This is said when there is an increase of 2 or more than 2 points on the SOFA score from the baseline value. There was a baseline SOFA score of the patient, and if after some time the patient develops, the score increases by a point of 2 or more than 2, in that case we say that the patient is developing organ dysfunction. And if that along with it, if the patient has infection also documented, systemic infection, then we say that the patient is going into sepsis. This is the new guideline of sepsis. Okay. Now, what is the definition of septic shock? But before starting septic shock, I will tell you about a concept which is no longer used, is severe sepsis. Okay. Severe sepsis is essentially an old concept in the previous guidelines. It was given in old guidelines and it's no longer used. What it defined, what it said was sepsis plus dysfunction of more than or equal to 1. If in the patient of sepsis there is dysfunction of 1 or more organs, we say that the patient is going into severe sepsis. Okay, so this was the severe sepsis, not used now. So sepsis, now coming to septic shock. So if we again talk about the old guidelines, it was severe sepsis plus hypotension. So sepsis plus organ dysfunction, which is essentially severe sepsis, plus hypotension. The total hypertension was an SBP of less than 90 or an MAP of less than 65. So this was the old guidelines of sepsis. Now what does the new guidelines say? So we know that septic shock is a type of distributory or vasodilatory shock. So the new guidelines, essentially they say that the patient should have sepsis, and we define sepsis by an increase of 2 or more than 2 score on the SOFA scale plus infection, as already told you above. So sepsis should be there, plus there should be requirement of a vasopressor. And why do we need vasopressor? To keep MAP more than 65 mmHg. Okay, so we are not talking in vague terms now, we are talking in absolute terms now. The patient has sepsis documented, and in this patient we need to give some amount of vasopressor so as to keep the mean arterial pressure of the patient above 65 mmHg. And along with that, there is lactate level of more than 2 millimole per liter. Okay, so we are going towards much more objectivity now. The patient should have sepsis, the patient should have shock or hypertension requiring vasopressors to keep the mean arterial pressure more than 65, And on an ABG, the lactate of the patient should be more than 2. If these guidelines are met, we say that the patient is going into septic shock. Management of septic shock. As I told you, first of all, we always give the first line is the fluids. I told you there is no ideal fluid. So what fluids can we give? Crystalloids, colloids, and in colloids what we use is the albumin. Okay, these two are equally effective in a patient of septic shock. A lot of studies have been done, and what they have concluded is that crystalloids and colloids both are equally effective in a patient of septic shock. You can give either of those, but the other colloids, hydroxyethyl starch and pentastarch, are not to be given, since they increase mortality. Hydroxyethyl starch and pentastarch, a lot of our studies were conducted, and what they found is that both of these, they increase the morbidity and mortality in these patients of septic shock. So if asked, we have to give crystalloids or albumin, not colloids. Crystalloid or albumin. Other colloids, hydroxyethyl starch and pentastarch, are not to be given. And we give these fluids at a rate of 30 ml per kg, except an obvious contraindication in patients of pulmonary edema. If the patient is in pulmonary edema, you need to restrict the fluids. But if not, then you can give the patient boluses of 30 ml per kg easily. Okay. Now, the second thing in these patients, vasopressors we give as and when required. But the most important thing in these patients of septic shock, the most important thing apart from fluids, is antibiotics. Okay. First thing, what is the optimal timing of starting antibiotics? It has to be started within 1 hour of the patient presenting to the hospital, preferably after taking a blood culture. You have to take a blood culture first, then you start the patient on antibiotics, and preferentially in 1 hour of the patient presenting to you with the symptoms. Okay. So within 1 hour of presentation after taking culture. Okay. Now what are the regimens used? The regimens are broadly divided into 2 categories. The first one, if we suspect that there is not going to be any pseudomonal infection or pseudomonal etiology, in this case the regimen is different. And if we suspect that pseudomonas may be one of the causative organisms, then in that case the empirical regimen to be given is different. So first, if no pseudomonas suspected, this is the generally used regimen. Okay, generally we don't suspect pseudomonas to be present in the culture. Generally what we find are E. coli, Klebsiellas. So pseudomonas are not generally not found. So this is a generally used regimen. If they are not mentioning that we are not suspecting pseudomonas or we are suspecting pseudomonas, they are just asking what is the empirical therapy to be given. Then in this case, this regimen is the one that you are supposed to choose. So what the regimen is, we give the combination of vancomycin plus ceftriaxone. Instead of ceftriaxone, the other one which can be used are cefotaxime or Cefepime. Okay, but what the generally is asked is the vancomycin and ceftriaxone combination, and as we know, ceftriaxone and cefotaxime both are third generation cephalosporins, and cefepime is the fourth generation cephalosporin. Okay, this is the regimen if we do not suspect Pseudomonas to be there. But if Pseudomonas is suspected, then what we will give? In that case, the first drug remains the same, so we will give vancomycin plus cefepime. So now ceftriaxone is not given, cefepime is given because cefepime acts on Pseudomonas, and we will add another drug. Now we will give three drugs. The third drug is usually Norepinephrine. Instead of cefepime, ceftazidime can also be used, and instead of meropenem, mepenem can also be used. Okay. Now the other drugs which can be combined with vancomycin apart from these are piperacillin tazobactam or ciproflox or gentamicin or amikacin. Okay, this is the management of septic.
Thanks for watching. Hope to see you again in next lectures and presentations. Do not forget to share and like the video. With my best wishes, Dr. Atf Ahmad, and visit my website, dratf.net.